Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Hello, my friends. Thank you for joining me on this very special episode with my friends, pediatric dentist, Dr. Nick Sharma and Dr. Nash Cassim, who are going to talk about my favorite topic, which is preventive dentistry, minimally invasive dentistry, but also my favorite patient group, pediatrics. So, Nick, welcome back to the podcast. Please tell the audience about yourself.
Thank you for having me again. It's good to be back, and it's a topic that I'm interested in as well. I kind of call it the put the drill down and do something else. So it's not always necessary to grab the drill. My name is Nick. I did my dental school at McGill and moved to Toronto after I practiced pediatrics a little bit in Montreal itself. Now I practice out of private practice, but I also teach CE with Nash, and one of the topics we teach is minimally invasive dentistry. So this is right up our alley, and we're definitely excited to talk about it.
Oh, we're so excited to learn from you, Nick. Thank you for joining us again. And Nash, you're one of our first timers on the podcast. So welcome. Please tell us about yourself.
Looking forward to starting my podcasting career. I was practicing my podcast voice this morning. My name is Nash Cassim. I'm a pediatric dentist based in Toronto. I did all my training in Toronto, dental school at U of T, pediatrics at U of T. I did a GPR at Sick Kids. Following that, I started working in private practice. I worked in a hospital setting, and I also teach as an assistant professor at the university. So kind of a lot of different hats that I wear. Like Nick mentioned, we do run a CE course for pediatric dentistry for the general dentist, which is Little Smiles Learning, as you can see on my shirt here. And that's been a really, really fun project to help general dentists get better at treating kids, because if you're a family dentist, you got to treat kids too.
Yes. And Little Smiles Learning, like you've been giving hands-on workshops across Canada. So we love how you're helping GPs. And I also love how you're helping my study club. You provided a hands-on presentation in the fall to the New Dentist Study Club in Toronto. And it was so well received that I thought, let's make it into a podcast. Let's talk about some ways that we can treat kids without picking up the drill. So Nash, tell us about silver diamine fluoride.
Right. So silver diamine fluoride, or I'm going to call it SDF for short, so it's not as much of a tongue twister, is a great, great material with a lot of applications. It came out of Japan, where they were using basically silver nitrate to try to arrest caries. And what they realized was that silver can completely arrest caries. And so we use it in a formulation which is a combination of silver and fluoride in a very, very high concentration of fluoride. And we use it for a wide range of things, anywhere from preventive all the way to actually interventional dentistry. So for kids that come in that maybe have some incipient caries, SDF is really useful to help tip that balance in our favor and move away from a demineralizing to a remineralizing mouth. In terms of interventionally, we use SDF on active cavitated carious lesions, especially on kids where we want to try to prevent any more intensive or invasive intervention. So the classic case is, you have a really young kid. They're not going to sit in the chair, to pick up a handpiece and try to do fillings on their teeth. But you can get a microbrush in there and get some SDF on those carious lesions. Best case scenario, that's actually going to arrest the caries, so it's no longer active, and you don't need to do anything else other than just wait for the teeth to fall out. And worst case scenario is it slows it down so that the kid can get older, more cooperative, and then potentially sit in the chair and get the work done. So it buys you time in the worst case, and in the best case, it solves the problem.
I think Nash, I was just going to add something quickly. And I think one of the things that I find it useful for GPs is that if you're referring to a pediatric dentist, sometimes the wait could be quite long. So at least you're doing something before sending these patients out. And by the time they get treatment, at least we've kind of arrested the progression, like Nash said. So that's always a benefit as well.
Well, thanks for pointing that out, Nick. Now, Nash, how about black stain?
I mean, if
anterior teeth.
Yeah,
what are
SDF,
parents saying about that?
SDF, if they made one that didn't stain, which I think is in the works, would be like a miracle drug, honestly. Yes. The one and only downside is the staining. So it does stain the carious portion of the tooth a dark black color. So not the entire tooth, but where the carious lesion is. Now, for example, if we have incipient caries interproximally that we've picked up on a bite wing, we're not really going to see that staining because it's interproximal. So I think that's very well accepted by parents because it's not really something aesthetic. Where we get into concern is when it's on those front teeth. So, the child that's been using a bottle and they have that nursing caries appearance on the front incisors. Now, often what I find is in those kids, when it gets to that point, the caries doesn't look amazing either. It's usually a dark brown color. So a switch from dark brown to dark black, most parents can get behind that if it means that, guess what, your kid doesn't need to go to sleep under general anesthetic in order to get these teeth treated. Or, we may not need to extract these teeth if they're getting to that point if we leave things alone. So it's all about risks and benefits. And I find if you frame those two things together, it contextualizes what we're doing. And often parents, will pick the health of their child over the aesthetics of their child. And so for SDF, I find, yes, it does stain the caries black, but most of the time when I frame it in the context of this can avoid a general anesthetic, this can potentially avoid having to extract these teeth, a lot of parents are on board with that.
Great. And Nash, how often should we apply it?
So by the book, you do want to do it twice a year. So typically when I do SDF, I try to apply it 2 times within like a 6-week span. And then after that, you can technically apply it twice a year for the most optimal effect. So I would say twice a year is what we're aiming for. And the application is quite easy. You don't need to book an hour to do it. It's a 15-minute appointment. The kid comes in, you put some Vaseline just so you don't stain their face. You got a microbrush and you apply it where you need to apply it. It takes, 30 seconds to do, and it's a great service to patients.
Oh, great. Now, what if, the kid's so uncooperative that you can only apply it for 10 seconds? Is that still effective?
Still effective. I think in an ideal world, you put it on for a minute. The kids I see don't really read the textbook and know that they need to sit still for a minute. Sometimes they're 1 or 2 years old. I have maybe 20 seconds to get that in there. You do the best you can. Try not to make a huge mess. It will stain your pants. It'll stain your countertops. It'll stain your chair. It'll stain everything. So be really, really, you just need a small amount. You don't need a lot of it.
And it doesn't taste great. So I like putting regular fluoride varnish over top. And then it actually makes it stick to the tooth longer. And then, they're not trying to spit it out and brush it off. And
and definitely if we're doing it in the posterior, I like to have that suction right there on the lingual side, so that it's not getting to the tongue and we're getting it all out before they taste it.
Okay,
while we're on the topic of SDF, I just wanted to add the taste was obviously one of the concerns, and then the aesthetic appearance is one of the concerns. But while I was in the US, they actually presented a new product that's coming out, and it's clear SDF by Young. Again, no financial conflict of interest over here. I don't really know the brand. I don't really know the product, but from what I saw and tasted it myself, it was actually no flavor, no taste, and it's clear, and it's supposed to stain closer to that yellowish type of staining rather than a gray or black. So it is very promising. Obviously, everything comes to Canada 5 years later. So hopefully in the next 5 years, we'll see this product come out here. Yeah.
Awesome. Now, any contraindications to SDF?
Yeah, so if there's a documented silver allergy, it's rare, but it is possible. So you do want to ask about silver allergy, and obviously you don't want to use it because it is silver. If caries are really deep, or we're starting to get pulpily involved, so if there's symptoms of pain, it may not be the best idea to put SDF that close to the pulp. And if there's an infection, it's a bit too late for SDF. So if there's an abscess, the tooth is non-restorable, the SDF is not really going to solve any problems there. So I'd say silver allergy is like the number one thing where we just definitely don't want to use it. And then anything where the caries might start to become pulpily involved, where you have symptoms of pain, we maybe want to avoid SDF as well.
Awesome, Nash. Now, I just used SDF yesterday on a 3-year-old, and I told the parents, hey, when he's a little bit older, we can actually restore these teeth. Now, what if next year he's still uncooperative, but I want to restore the whole, Nick, what do you have to suggest?
Yeah, so I think this is what we call the technique SMART technique. So it's silver modified, so SDF modified ART. And ART and ITR kind of go hand in hand. But what we're doing is we're just removing a little bit of the decay, trying to remove all the soft, mushy decay with a non-threatening instrument. So that could be a spoon excavator or even a round burr if you can get one in. And then once you kind of remove that, you're applying a GI or an RMGI. Now, when we do this with SDF, like you said, for your case, it's
Mm-hmm.
perfect. You've done the SDF, you kind of follow up, you've arrested the decay, and now you feel that, okay, I just want to fill up this crater. So you can apply a GI or an RMGI, and the main difference is, one has a longer setting time than the other. Is difficult handleability, I guess, because
Mm-hmm.
you have your the difficult handling because the GI will be a little bit more moisture sensitive, but at the end of the day, you are able to, still get it to set. It is self-cure. Whereas our RMGI will be most likely light cure or dual cure, and you'll get a little bit shorter time, but you do need a little bit more isolation.
Mm-hmm.
So you have both options depending on what type of child you have and what type of cooperation you have. You could use either or. The good thing is that they both release fluoride. They'll give that whitish appearance over that black and fill up the crater. Now, sometimes this could be your final restoration until maybe they lose the tooth or the tooth is asymptomatic and not progressing in decay. But sometimes it could be, for us, a lot of the times it's like an escape route or a plan B.
Yeah.
I cleaned up the tooth. I have the isolation. I'm almost done doing the etch bond, but I lose cooperation. Or
Yeah.
I don't even get to the etch and I lose cooperation. At this point, I can just fill the chamber up with this sedative dressing, but it ends up being a restorative filling. The other scenario is, you removed most of the decay, you got all the walls clean, you still have some left on the floor. You can put this fluoride releasing temporary restoration as a plan B and send this patient either to a pediatric dentist or follow up and try again when there's more cooperation.
Yeah, I
Mhm.
love using glass ionomer. So let's get back to my patient from yesterday,
Yeah.
3 years old. What if I found that, okay, he was pretty cooperative with the SDF. I think I could put my GI in right now. So what do you think about putting the GI right after the SDF? Any concerns?
So, I mean, I guess we'll both comment on that because maybe we do it differently. I mean,
Yeah.
I'm totally okay with doing it the same appointment. Ideally, you want to see some decay arresting before you put something over it. So
Okay.
it's nice to do that at the follow-up appointment. So like
Okay.
Nash said, within 6 weeks, you're doing that second application. Maybe that's a better time to do that
Okay.
GI. However, if you don't know if you're going to be able to get this patient back or another application or
Yeah.
cooperation is starting to go downhill and you're like, I don't know if I can go back in there, then applying it the same day is not the end of the
Okay.
world. You're still doing some benefit, right? So at the end of the day, I think
Yeah.
either or.
I agree with Nick. I mean, the one downside is if you do it at the same time, you can stain your GI or RMGI because the silver is just kind of activated. And so you may get more of a grayish restoration than like a more white colored restoration. I mean, if this is something in the posterior where aesthetics isn't as much of a concern, once again, it's a risk benefit thing. And kids tend to do best at the first appointment where you kind of get as much done as you can. And then when they come back, if you have to redo stuff that they didn't like and they remember it, it's a bit harder of a sell. So I find that I always try to minimize the number of appointments a kid has to go through. I find that cooperation just generally tends to be more agreeable if they have to get this stuff done less. So I personally like to do everything at once.
Mhm.
But I think it depends on your patient population and how you choose to use the SDF.
Yes. And yeah, really good point. If you were going to light cure something over the SDF at the same appointment, the silver from the silver diamine fluoride is going to leach out into that white colored restoration. So you are going to get a dark restoration.
Yeah.
So in that case, I would use the SDF and then a self-cured glass ionomer because then you don't need the light. And you can use fast set. So they'll like
Yeah.
set in a minute. And so, you know, for everyone listening, if you're going to put a composite or light cured resin modified glass ionomer over top of SDF right after you applied SDF, you're going to have a dark restoration. So just wait at least 2 weeks and then put a light cured restoration in if you want to use a light cured restoration.
Mhm.
Agreed. 100%. Yeah.
And I also use glass ionomer as a base under large
Yes.
fillings.
Yeah.
Yeah.
So I think
Mhm.
glass ionomer, like initially, if you look at it in restorative, it is exactly for that, right?
Yeah.
For a base, for a liner. We have liners that are, just out of syringes and you're kind of pouring them into the bottom of the cavity. But I think it serves the purpose of exactly what we're trying to talk about for pediatrics is that, you want to refer this patient to a pediatric dentist, but at least put something before you send them
Yes.
because it can serve as a benefit to the child as well.
Yeah. And if you're using it as a temporary restoration to hold them over, like glass ionomers are really durable restoration, much better than putting Tempit or IRM. It's going to last a
Yeah.
lot longer.
Agreed.
Yep.
Yeah.
Yeah.
Especially on the type of lesion, right? If you have a one surface, that's gonna hold as good as a permanent restoration.
Yeah, it will. Now, Hall crowns. I've done some Hall crowns. A lot of people don't even know what they are. So,
Yeah.
Nash, do you want to talk about Hall crowns?
Yeah, so hollow crown is a technique that it actually came out of Scotland. And basically what they were finding was uh, time and the number of patients was a huge issue. They just have too many patients, not enough time, limited resources. And so the technique is basically you have primary teeth with likely multi-surface caries. So we talked about ITR, ART with GI. The more number of surfaces that are involved when you're trying to place this temporary material, the less success you're going to have. And so as the number of surfaces increase, the less likely that an ITR or ART is going to work. And that's really where hollow crown came around. So a hollow crown is essentially a technique where you have a multi-surface carious lesion on a primary molar, and you basically just place a stainless steel crown on it. You don't prep, you don't give local, you don't really do caries removal unless there's just some mush that you want to get rid of, but you don't have to. And you take a stainless steel crown, you put a GI based cement in there, and you just cement that on the primary tooth without any work on the tooth. And what that does is that one creates a hermetic seal around the tooth and the caries lesion. And that changes the microbiome. Remember that caries is a microbiological process, and we need bacteria and a substrate for which the bacteria can metabolize and create acid. And so if you create a hermetic seal around that lesion, you're not getting that substrate. That sugar is not going to get into the caries lesion. That bacteria cannot activate. And so that kills the bacteria essentially. So you're changing that microbiome, you're changing the substrate that can get in there. The second benefit with using a GI-based cement is that release of fluoride. So you're going to get this burst release of fluoride as you cement this crown, and then a continued kind of recharge and release of fluoride. And that fluoride is going to help remineralize the demineralized portions of the teeth, as well as kill other, bacteriogenic or cariogenic bacteria. And lastly, you're basically protecting the tooth, right? So now that the tooth is covered by a metal crown, you're not really going to be able to get a new cavity forming through that. So you've basically solved several problems at once. And what the research shows is that this technique can be quite successful. Depending on studies that you look at, it ranges from anywhere from 70 to 96% successful.
Wow.
And we have to remember that our goal with baby teeth isn't that you have a restoration that lasts forever. It just needs to last the lifetime of the tooth. We have the benefit of baby teeth falling out. So the goal is just to stabilize the mouth and then allow the teeth to fall out without having to do anything more interventional. So that's where hollow crown came from.
Yeah, the Hall crown is so cool. There's no local anesthetic involved, no drill, so no prep. You're just popping a crown over the tooth.
Yeah.
Now, does this hurt?
So it can be uncomfortable. So I think you still need to use your behavior management, right? Remember, this is still a child in your chair. It's still a procedure that you're doing. Yes, it's more minimally invasive than a conventional stainless steel crown, but it's not always just, the drill and the local that kids are upset about. It's the taste, it's the time, it's opening their mouth, it's water, whatever you decide to use. So you still need to use your behavior management. You still need to use that distraction. The parts that are the most uncomfortable are actually just placing the crown, because there's a lot of pressure and it can feel a little bit tight in that area, especially with the gums, as the crown tends to be a bit bigger because we're not prepping. So the way you can overcome that, one is you can use a bit of topical, right? So if you use a little bit of topical in the gums, around the gums, that's going to help with that sensation of pressure. It's going to help with the discomfort. And then, I think you don't want to do this multiple times. So, you don't want to put the crown on and take it off and put it on and take it off. Just do it once, right? So that the kid doesn't have to go through this multiple times. One last tip that I'd recommend is a lot of times kids don't like that pressure. As you push the crown down, it separates the adjacent teeth, and that can be quite uncomfortable. So one thing you can do is place separators in advance of the appointment. So orthodontic elastic separators, you can place that, 3 to 5 days before. When they come back, there's nice spacing between the teeth. Now that crown's going to slide on super easy without much force, much better tolerated by kids as well.
Okay, good. Now, what if you don't have that initial appointment where you can put in those elastic separators and there's no space mesiodistally? Can you just push the crown down and it creates the space?
Yeah, you could push hard enough to get the crown down. Like if you think about orthodontists, they put banded retainers, all sort of stuff. Now you could place separators in. I've done separators for like 15 minutes and gone and done a hygiene check, drank a sip of my coffee, came back. There's enough space because primary teeth don't need a lot of force to move. Remember, they're not, super
Okay.
long-rooted molars, they're baby teeth. So
Yes.
15 minutes with a separator will probably get you enough space.
Oh, excellent. Thank you.
The only thing I was going to add on Hall technique where I wanted to kind of just clarify is we kind of keep these because everyone always asks, well, why don't we just do this for everyone then? Why are you
Yes.
prepping? Why are you numbing them? Why are you
Yeah.
sedating them? I think this is a good technique if you have like one tooth. You have a kid who's 3, 4 years old. You kind of don't want to sedate them for one
Mhm.
tooth. You don't want to necessarily put them under general anesthesia for one tooth. So this is that perfect case and scenario where you do one Hall crown. You don't want to anesthetize them. You don't need any help from sedation to do this. And you've kind of just taken care of that one tooth. Now, if you have multiple quadrants, multiple areas of the mouth, then it's probably as a GP, it's either you try to do multiple appointments or you
Yeah.
refer for sedation to a pediatric dentist.
Okay. Good point. Now, Nick, what do you do about the occlusion? Because you didn't do an occlusal reduction. It's going to be higher.
Yeah, so the good thing about pediatrics is that it's very adaptable, and kids don't complain as much as adults do. So sometimes, even I'll be polishing a filling, and I'm like, okay, I'm losing this kid. We've tried so many times to check the bite, and I'll just be like, I think it's fine. It's within 1, 2 millimeters. We'll be okay. And I've never had a kid, knock on wood, complain or come back. My filling is too high.
Yeah, it's true. They
So
never do.
they never do. And they go back to their normal diets, eating, activities, everything is fine. So I think with the stainless steel crown, it's the same in general. Even when I am prepping and reducing and able to do the full procedure, I get a pretty good occlusion stability, right? The only thing is it's never going to be perfect because is the kid exactly biting how I want them to bite? If they're
Mm.
sedated, are they biting the way they're supposed to? And I've never seen an issue with that. There's always some adaptation room. I wouldn't crank it open 4 to 5 millimeters. You're obviously on the wrong crown if you're doing that.
Okay.
But if you're within, 2 to 3 millimeters, it's not the end of the world. And I'm sure, Nash, you can add to that as well.
Yeah, if you look at crowns and opening of bites, they usually will settle within 4 to 6 weeks. So even if you did open the bite a
Okay.
couple of millimeters, the primary dentition moves around, right? That's why we need space maintainers. That's why we're so
Mm.
concerned about maintaining primary teeth because they move. So even if you do open that bite a little bit with your crown, it will settle within a few weeks. So obviously, yeah, like Nick said, don't try to crank it open 10 millimeters, but a couple
Okay.
millimeters is very well tolerated.
Yeah.
Okay. Excellent. Now, I would love to hear about the latest product called Papakari. Like
Yeah.
it's a papaya enzyme that actually removes decay without a drill. Like tell us about
Yeah,
that.
it's kind of sounds unbelievable at first because papaya, you'd never think of it. Who actually tried putting papaya in
I
there?
know.
But the ingredients are pretty cool. There's 3 ingredients, and I actually looked them up. So there's papain, chloramine, and toluidine blue. The later two have to do more with disinfecting and antimicrobial effect, as well as giving it that bluish appearance. It actually looks exactly like etch if you've looked at it. But the main ingredient itself is the papain, which is the protein from a papaya. So what it actually does is if you have decayed dentin, it doesn't it doesn't have the protein required to break this down. So that papain enzyme will actually be able to act on the decayed dentin rather than on sound dentin. And
Okay.
what they report is that it actually softens that decayed dentin. So going from the discolored, slightly hard, slightly leathery to now mushier decay, which is a lot easier to remove with a spoon excavator. If you have a round burn there, sure, it will be even easier, but at least a spoon excavator will be able to do the job. And the way you're applying it is literally like etch. It was a little bit of a learning curve or case selection for me. The first few cases, I was kind of like, oh, let me just apply it. And it didn't really get softer, but it's because of the way I was applying it. If you have
Mm.
a small occlusal hole, for example, you're not going
Mm.
to get all the contact from that substance onto that decayed dentin. It's going to stay on the top or it's going to stay on the walls. It just doesn't penetrate
Okay.
enough. So I started looking for cases that had, larger holes, more access of the material. I can see the mushiness, but then I can also feel the hard decayed dentin. And that's when I started really pushing it in with a micro brush sometimes as well, and then leaving it for at least 30 to 60 seconds. I find that the longer I left it, closer to that 60 seconds, the better and easier it was to remove all this decayed dentin. So pretty much you rinse it off after 60 seconds. You take a spoon and it is supposed to be coming off a lot easier than when you had initially checked. And I think it's promising. I've only tried a handful of cases and I want to keep trying them on the different types of cases, enamel hypoplasia versus decayed.
Mm.
Does that make a difference? Dentinal, I guess, issues as well. Will it cause sensitivity? Will it nause? Do I need to anesthetize? So these are all things we still have to consider, but it's supposed to be minimally invasive. It's supposed to be just application and spoon excavate, right? So this would be another tool in addition to the ones we just spoke about, which could be great and could be very promising for even GPs to do, but even pediatric dentists, us too, we can kind of use that if we're working with a non-cooperative kid.
I just want
it's
to
really
tag on to Nick before we, for pediatrics, I think you need to have a lot of tools in your toolbox. There's never one size fits all for any kid. Every kid is a unique situation and every tooth's a unique situation. So nothing is going to be the perfect solution. Sometimes you mix and match, sometimes you modify, and that's fine. That's pediatrics. You got to be creative every day.
Yeah, I like that. I like how promising papakari is, not just for primary teeth, but for permanent teeth as well,
Yeah.
because the American Dental Association came out with restorative guidelines for moderate and deep caries. They said, do not do complete caries removal because you're going to hit the pulp or get next to the pulp.
Yeah.
Instead, just remove that affected, like the infected dentin, the soft, mushy stuff, and leave the affected dentin. So sometimes it's hard to tell the difference. What's infected, what's affected. So there was Papa Carey's product manual just said, like, use it for that. Use it to differentiate between infective and affected so you're not drilling too deep.
Yeah, because at the end of the day, if it doesn't come off, then that's the part technically you
Yes.
can leave. You can still
Yes.
use a liner, do all that GI
Yes.
stuff that we talked about, and just exactly like Nash said, put more tools in there without necessarily exposing the pulp and now putting that spiral of tooth death, right?
Yeah. I'm like picturing both of you like with this like Home Depot type of vest with all these different things in your pocket, like a tool vest. And you're like, okay, let me try this. Let me try that.
It
That's
feels
that's
like that
exactly what it
sometimes,
is.
right?
Yeah, sometimes you go in there we talk about this in our workshop and we say we set up or the treatment plan says stainless steel crown, but our assistant sets up for 3 different procedures and like each tray is ready to go because you just don't know which way you're gonna end up going. So it's good to have.
Yeah, that's what makes pediatrics fun.
I
No.
guess, yeah, fun sometimes and sometimes you just really don't know
Stressful.
what to expect.
My
So
poor
don't expect
assistant.
anything.
That's right.
I like how Nash said creative. Yes, you have to be
Yeah,
creative.
Yeah.
that's
Now,
it.
how about, there's the last thing I want to talk about. Either one of you can talk about it or both, but fluoride varnish. Like, is that also like an easy way to
Yeah.
solve
I
primary
guess
tooth decay without a drill?
Yeah, I could start off on that. I think fluoride varnish is great. I've used it for, the young kids as well as the older kids, but young kids specifically, when you start to see those enamel decalcification
Yeah.
on the incisors, I think it's great to get started on that. Now I know there's all this talk about fluoride and controversies, I guess.
Yeah.
It's fine. Let's not talk about fluoride in the water, but in terms of fluoride actually being topically applied, it
Mhm.
does provide both antibacterial effects as well as remineralization. So if you're trying to avoid the drill, you might as well start a little earlier and apply that fluoride varnish and let it penetrate and let it allow remineralization,
Mhm.
especially in those white spot lesions or those lines that form along the gum lines. So I definitely use it for those cases, and I do it at a 3-month frequency and in high risk patients. And you've seen it at least delay the caries
Mhm.
progression.
I think, the earlier, I'm a big advocate for early intervention and early screening. Bring your kids to the dentist by the first birthday. The earlier we catch something, the less invasive we can be with our intervention, right? So I think
Mhm.
fluoride varnish is the least invasive thing we have, right? It's extremely safe. It doesn't discolor the teeth. And there are programs out there where they're really, really aggressive with the preventive management for patients. And that involves one-on-one dietary counseling, goal setting, um, successive approximation of goals and motivational interviewing. And so there's a program that's, I think, out of Boston where they, like, for any patient when they're planning for, more interventional care, they have a very, very strong preventive approach first. And they're often able to arrest caries. Like, I look at these pictures, I'm like, oh my goodness, how did they arrest these with just fluoride varnish? It has cavitated
Wow.
brown lesions that are glassy hard, no SDF, no GI. All they did was change the diet at home, change the hygiene, and fluoride varnish, and they were able to arrest
Wow.
caries. So it's possible. It takes a lot of
Okay.
motivation. I think you need the right family and the right patient,
Mhm.
and that's where patient selection comes in. If they're highly motivated and they're willing to make those changes at home, you can arrest caries with just fluoride varnish. but it's a team effort. There needs to be change at home as well. It's not just our intervention. It's a collective effort.
One
Oh,
tip that I give usually to the parents to add on to Nash is when you're
mhm,
trying to motivate them at home, I tell them if you can see the white spot lesions on the incisors, I just tell them take a Q-tip, take either a fluoride toothpaste or a
mhm,
fluoride rinse, dip it in there, and every night before they go to bed, just topically apply it. Because sure, they're coming to us every 3 months or every 6 months to apply that fluoride varnish, but what happens on a daily basis is going to be far more powerful at this
yes.
prevention than once a year.
Yeah, good tip. As on top of, the motivational interviewing and the dietary changes, because it doesn't matter how much fluoride we put on the teeth, how much
Yeah.
brushing and flossing, sugar is always going to win.
And
Mhm.
and that's the thing with pediatrics is one of the huge sections that we learn about is anticipatory guidance. So it's pretty much educating. And that's why those first
Yeah,
visits at first birthday is not so much to check the teeth. There's 4 teeth, what are we going to
it's
check?
true.
It's more to educate the parents so that we can get them on the right track. And this way they know about diet, hygiene, and you're not actually trying to catch up later on in life.
Yeah, and harm reduction is really important because it's really hard to tell someone don't eat sugar. Like we still eat sugar. So
Yeah.
at least you can say things like, okay, if you're going to give your child a juice box, like take it away from them after 5 minutes. Don't let them
Yeah.
sip on it the whole like walk in the stroller to the park because
Yeah.
now they've had the sugar on their teeth for half an hour. So like there's little ways that we can prevent caries without a drill, not just in the office, but with the
Yeah.
education we get.
And most parents don't know that, carbohydrates, starchy carbohydrates are the
Yes.
issue, right? It's not so much, we all associate sweet and sugar with
Yes.
cavities, but the other half of the diet that nobody really knows about is the starch, right? So I think
Yeah.
educating that,
Yes.
sometimes you'll get parents surprisingly like that I'm talking about crackers that are salty.
Yes.
Why is that a risk? It doesn't make sense. So yeah.
That's definitely one of the biggest misconceptions out there that I've seen is, this association with sugar and cavities, but not necessarily starch and cavities.
Yes.
And then also the two other big ones I see are natural sugars. So this
Yes.
concept that, because it's derived from natural sugars, it's healthy. So apple juice with no added sugar
Hmm.
is fine because it's natural sugars, but it does the same thing to the teeth. Or
Yes.
things like, dehydrated or dried fruits. Yes, it's a
Hmm.
raisin. Yes, it's a natural sugar, but it's sticky and sweet and does the same thing.
Yeah.
And then the other thing is quantity versus frequency. So we know that the
Yes.
evidence, if you look at the Steffens curve, the frequency of carbohydrate intake is way more important than the quantity. So parents say, oh, they don't have much of a sweet tooth. They barely eat this stuff. I give them like one cookie now and then. But, eating one cookie every hour is much worse than eating 10 cookies
Yes.
in 5 minutes.
Yes.
So, flipping that switch, that's where I really see like a light bulb click and parents are like, oh, yeah, he does tend to graze. He's a nibbler. He eats a little bit all
Yeah.
throughout the day, and that's actually worse than just eating it all at once. So like,
It's
switching
true.
switching things a little bit, switching the order, switching the frequency, you can still have what you like, but just do it
Yeah.
in a harm, like you mentioned, Sam's, like kind of
Yeah.
harm reduction. Have it all at once and then take it away.
Yeah.
Exactly. But that's so important because we've become a snacking environment, like a snacking culture.
Yeah.
Hmm.
So, the strollers are even designed for snacking, where they have like snack trays now,
Yeah.
juice box holders. So, we really have to educate the parents on that because it goes against what culture is saying, which means like eat and drink all the time.
Hmm.
Yeah.
So yeah, definitely, promote that first visit by the first birthday. So that way we don't even have to use any of this stuff
Yeah.
like
Yeah.
SDF and Hall crowns. We can just say no cavities, kiddo. See you in
That's the
6 months.
best.
That is our goal.
Prevention in itself is a minimally invasive tool in our toolbox, right? We just
Yeah,
don't forget to use it. So
that's true. Yeah, really good point.
yeah.
Now, Nick and Nash, that has been fantastic. We learned the importance of using SDF, Hall crowns, glass ionomers, papakari, fluoride varnish, dietary, education. Now, is there anything else you'd like to talk about?
I think, like I said, in terms of new innovations, look out for that clear SDF. I know there's also the SDF tips that are coming out with oral science soon. So it's going to be
Oh,
literally
good.
a tip rather than a drop that you have to carry over.
Oh,
So
excellent.
making deliverability a little bit easier. Yeah.
Yeah.
Oh,
And for the listeners that want to learn more about pediatrics, Nick and I do run workshops across Canada, and we're finishing kind of our final leg of our Canada-wide tour. So we'll be out in BC in September, we'll be in Calgary in October, and then coming back home to Toronto in November to to wrap up our 2025 tour. So
Excellent.
if you're interested in those things, please reach out.
Are there any spaces left in those workshops?
So we have Calgary. We definitely have spots in Calgary. In Toronto, we started a wait list, and our next date will be in January. So you'll be able to find everything on our website in terms of dates and wait lists. Our website is littlesmileslearning.ca. So just click on that and you'll be able to see exactly how many spaces at each of the workshops.
Yeah, for everyone listening, you have to go and check out Nick and Nash's hands-on workshop. You're going to not just learn the skills, but the confidence. And Nick and Nash are so great that afterwards, they'll provide you with support, which is so important when you do your first crown. They're going to be literally holding your hand while you do it. So Nick and Nash, thank you once again for, helping new dentists with this very informative podcast. So Nick, how can the audience reach you if they want to send you a message?
Yeah, so on Instagram, it's at Dr. DOCTOR, Little Smiles. We also have our own page, Little Smiles Learning. So you can reach out to us through that. And then Nash has his own Instagram as well that he'll share with you guys. But
Okay,
DM
Nash.
us whenever.
Yep, I can be reached on Instagram. It's Dr. Nash Cassim, DrNashCassim. Nick and I are very responsive on Instagram. I get messages all the time about, people send me x-rays. Hey, doc, what do you think? Like, I'm going to plan a crown. We are more than happy to guide people, whether you've been to a workshop or not. I think we're here as a resource to help dentists. That's what we want to do. That's our passion. So feel free to reach out to us if you have questions about your cases or treatment planning or about our workshops. We're more than happy to help.
Thank you, Nick. Thank you, Nash. Thank you so much for being so supportive and helpful to the community. And for the audience, have fun seeing children at your office. See more of them because now you have the skills to stop decay on kids without a drill. So thank you very much, Nick and Nash, and thank you to the audience for listening. Until next time, bye.
Thank you.
Thanks, Ange. Appreciate it.
Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.